Hello there. So thank you very much for tuning into this video. My name is Chris Morrow-Frost. I'm the Clinical Head of UEC Transformation and Improvement for the Midlands region. And this video with these distinguished guests that you can see before me is going to focus on ward flow and things, palpable things that we can do within our ward environments within acute organisations. And we're going to be picking the brains of these experts. They wouldn't describe themselves as experts, but I can promise you that they have great expertise to give. So hopefully their knowledge and experience will help. So we are going to do some introductions. I've introduced myself, and in no preferential order whatsoever. Gordon, would you like to introduce yourself?
Yeah, I'm Gordon Caldwell. I used to be a consultant down at Worthing Hospital in West Sussex, where I did quite a lot of work on ward round processes and feedback to junior doctors and improvement work there. I've now moved up to the west coast of Scotland, where I work in a very small hospital in Oban, where we've got about 55 beds, and it's the same staff that staff the wards as staff A&E.
Fantastic, Gordon. Thank you. We've already got a multinational panel, which is brilliant. Richard, over to you. So we do seem to have a connectivity issue with Richard. He did pre-warn us that he might have some connectivity issues. So we'll move on. Pete, are you there to introduce yourself?
Yeah, so hello, my name's Pete Gordon. I'm Head of Emergency Care Improvement for ECIST, the Emergency Care Improvement Support Team.
Excellent. And I can then move on to Tim. Hi, Tim.
Hey, Chris. My name's Tim Gillett, and I'm a Senior Improvement Manager with ECIST, working alongside Pete.
Nice to see you again, Tim. And Jyoti.
So I'm Jyoti Nipani. I'm a consultant in South Warwickshire Foundation Trust. I'm also a clinical director in the Emergency Care Intensive Support Team and currently the National Clinical Lead for Reducing in-Hospital Length of Stay.
Well, it's lovely to have you aboard, Jyoti. I can see that we've lost Richard, so hopefully he will come back to us. But I think it's a classic sign of the times, isn't it? In fact, I can see he's coming in now. Is that, of course, for those of you who are watching in the future, we're in the middle of this wonderful thing called COVID, which is enforcing us all to work in new and wonderful ways. And part of those wonderful ways is that we sometimes rely on broadband that's sometimes strong and sometimes weak. But Richard, are you there?
I'm here, yes. Apologies for disappearing temporarily, so I can.
No worries, Richard. Would you be kind enough just to introduce yourself to the viewers?
Yes, so my name's Richard Jennifer. I'm a consultant general physician and geriatrician, and I work at Chesterfield Royal Hospital in Derbyshire, and I'm also an ECIST clinical associate, having joined just before the COVID outbreak. And within ECIST, I'm also working as part of the Reducing in-Hospital Length of Stay team.
Well, fabulous. Thank you very much, panel. So the way we're going to do this video is very similar to a bit like question time. We've asked for some questions and we've picked some questions to put to this group of brains. And we'll see how we fare in the journey through the ward environment. So obviously, we've mentioned that we are in this COVID crisis. There's never been a greater challenge to our health service right now. There's a lot of focus on the front door. But the purpose of this video is to really focus on what can be done within ward environments. How can wards support good, timely patient care and flow? So that we could start off with our first question. So what contribution do we think as a panel wards can do to help expedite patient flow and good patient care? So in no particular order, Gordon, what's your thoughts on that question?
Well, when you asked that, I think back to when I was working in Worthing, and the last year I was there, when we had a complex patient for discharge, a frail elderly patient with multiple comorbidities needing care at home and such like, we decided that we'd try to make scheduled discharge time for that patient early in the morning. So maybe rather than send them home on Wednesday evening at 5, we'd do it Thursday morning at 9 in the morning. And what we found with that was the discharge went much more smoothly, but then we had an empty bed at 10 o'clock in the morning, and our lead nurse could go down to the emergency medical unit and choose which patient to take into that bed at 10 in the morning. That meant we could see that patient the same day, set up any more investigations. The next morning, we could answer the question, is the patient getting better and well enough for discharge? So with that, we found that our ward was full earlier in the day. We didn't have nighttime admissions. The night shift was easier. Patients slept better. And strangely, the overall length of stay, if anything, went down doing that. So we can be proactive with our emergency care areas. Thank you.
Thanks, Gordon. Is there anything in particular that that you've seen has been a good enabler in sort of understanding what needs to be done and when and at what time that helps you facilitate those discharges?
I think it was just planning probably 2 or 3 days earlier with these complex discharges that we're going to set a scheduled time for discharge. So very much my picture was of a plane taking off from an airport. No, it was always a scheduled time. It didn't just sort of happen to go on Thursday. It was going at 9 o'clock in the morning on Thursday. So I think by setting that time maybe on a Monday, it focuses everybody's mind. It may give people time to plan, got all the meds for discharge sorted out the day before. So it was proper anticipation and real planning to get the discharge on time rather than just on the day. Thank you.
Richard, have you got thoughts on the sort of that ward environment sort of checklist kind of strategy? You know, where we've got almost a prescription, if you will, of how to facilitate a good ward flow. You know, like a ward checklists or perhaps other mechanisms that you've seen used well.
Yeah. So. I mean, Gordon is probably too modest to mention himself, so he's certainly devised a lot of frameworks, perhaps, which you might call a checklist to create a bit of structure around how a ward process might work. I've also made use of checklists. I've tended to use the sort of checklist where you would see a patient and then quickly run through afterwards to make sure that you've checked everything, and there's certainly they provide an element of safety, but actually what you tend to find is that when people have their discharges delayed, often it's because we've failed to notice something and therefore failed to be able to act on something, which then leads to a delay down the line. It's always tempting to think that delays belong to somebody else, and actually an awful lot of them belong to us, and we've got the ability to make differences there. I think as well as checklists, another thing that's incredibly useful is introducing a huddle. Most places already have a huddle, but if you don't, it makes a huge difference. We had a ward that was it was designated as an outlier ward, and all the patients were just under a variety of consultants. And we introduced a huddle that was led by a geriatrician. Wasn't even necessarily the same person each day, but just by having that huddle, it actually brought down length of stay quite considerably on the ward. And then you can look at how you do the huddle and improving the processes. Yeah, I've got no doubt that having an effective huddle or board round at the beginning of the day can make a real difference to flow and the flows through the day. So alluding to what Gordon said about getting those earlier discharges, flagging up those people for that first discharge of the day can be really important.
Yeah, and I certainly in my experience, where you've got that leadership, it really has an impact, isn't it? So not only do you need that model to work with, so you've got consistency within the ranks, regardless of what the design is, but where you've got a group of people that agree to work in a certain way in a huddle, that's certainly quite powerful, isn't it? And in the ECIST world, Pete and Tim, that's something that certainly I think comes up quite often, isn't it? Have you? I think in the ECIST world is that you recommend certain methodologies to use in amongst huddles and ward rounds, don't you? There's something like the safer bundle.
Yeah, so I mean, we encourage, we try not to tell, and actually, when we think about things like the safer patient flow bundle, which is basically 5 sets of simple guiding rules, particularly for deeper inpatient medical wards. You know, a senior review. Let the wards decide what a good senior review looks like. All patients have a plan. The F is flow early. You know, give the wards, allow them to be able to pull the patient from the front end of the hospital. The E is the earlier discharge, and the the R is the reviewing of long-stay patients. I mean, but one of the lessons from that, Chris, is actually that it shouldn't be mandated. So we love things like that. It's a tool, and one of our lessons across the country is, having created it, then it's almost been regulated and demanded. And the framing of it should be around, what are we trying to do? We're trying to save patients time. We also don't want to make it too arduous for frontline staff, because that becomes all very irritating. But they're the type of things that we encourage. And I guess we also encourage red and green days, Tim, a little bit as well.
Yeah, of course, Pete. And so red and green days really takes that ethos of valuing patients' time to its next stage. So what are we doing for the patient today? What's going to happen today to move that patient towards discharge? Is everything that we've planned today happened? Does that happen? So it's about Richard's point about having that early morning huddle, that board round where you define what are we going to do today for this patient. And then I don't know, Richard, if you do this at Chesterfield, do you do the afternoon huddle, or is there a way of capturing at the end of the day, or Gordon or Jyoti, what has happened during the day? To have we valued patients' time today? Do we review that on a daily basis? Have you got examples of that, Richard?
So yeah, having a catch up later on in the day, I think, is really important, and it serves a number of purposes. So as well as picking up on the things that we've agreed to do, making sure those happened. But also, I think it really helps people to get away on time. And I think there's, we can't underestimate how important that is, that if people are consistently stuck working later than they're meant to, that has a hugely draining effect on morale. And it's also, it's actually not helping patients. So having some sort of catch up early enough in the day that things that need to be acted on can still be acted on. But late enough that you've had a chance to do some things, I think is really important, yeah. And it only needs to take, in fact, I'd say if it's taking more than 10 minutes, it's probably taking too long for that second catch up. I think there's often the fear that we're asking people to spend hours doing, repeated laborious tasks, and actually this is one of those things where the quicker the better, probably, because it's working really well if you can do it quickly.
Yeah, I was just trying to find that publication recently from the Royal College of Physicians on Physician of the Week, which I thought was a really good publication. Yeah. And on that, they have a very clear timetable for each day. And it happens that 3 or 4 months ago, we went across to Physician of the Week. We have a 9 till about 9:15 huddle where physiotherapists, occupational therapists, social workers, ward nurses are all there as well. Maybe goes on to 9:30. We catch up again at 12, we catch up again at 4:30, and then there's the night staff to hand over to them at 9 o'clock. So regular updates each 3 or 4 times a day. And what I really liked in that Physician of the Week paper was the simple timetable that they had stuck up on the wall. This is what we do at what time we do it, and keeping it, as you say, very short and focused. So, okay, we've found the CRP result. That fits with the patient getting better. They are going home. Who's done the discharge summary?
So I couldn't agree more, Gordon. I think that is exactly what I personally did in my trust years ago. The first thing we did was made sure that the clinicians, as you all said, that senior clinical decision making at the board round in a timely way, and access to this person who actually makes this decision is really important. They sometimes don't need to be physically there on the ward, but they need to be accessed. And you need to free them up of other duties so that they're actually approachable and accessible. So this is why we did this consultant of the week. We made sure that their job planned in a way that they actually are, you have to not just tell our consultants what to do or expect something to do, but you really need to enable them and put a system in place so that that can happen. So the job plans in the entire medical divisions were completely revised so that every specialty had consultant of the week, and that really gave the continuity. In the past, what used to happen was the 4 consultants used to walk into a ward at different times of the day, see 4 or 5 patients with their own team coming up, and each, 2 patients were getting same problem, but they're getting different treatments. It used to interrupt the board rounds so much. The nurses didn't know whom to follow. It was really chaotic. So the consultant of the week gave a good platform to have a single board round, single ward round, whole team working towards one goal, tasks actually generated, and you have this consultant accessible who can then say, why did that not happen? And the most important thing I find is, out of the tasks, if the consultant actually takes over the most difficult tasks, and then lets the juniors get on with the more easy ones. So referrals to other specialties, which are sometimes difficult, you take it over as your task, so that, you know, it's more difficult for a junior doctor to ask another specialty consultant to come and do a referral. So such things you take it up, and then it really it's a teamwork, and everyone in the team leaves the hospital together, so that everyone owns all the jobs.
That's really powerful. I personally love that, JT. It's really great to see our clinical leaders talking about workforce and actually measurable ways that you can make a change rather than sort of ethereal ones. So, but on kind of like the subject of tips then, is that if we think about the people that may be looking at this video, it's almost certainly people that are already engaged with wanting to make a difference. They know they're already sold on the idea that they need to or want to make an improvement within their own houses. Have you got any tips individually as to how you personally, if we've got a senior clinician or a senior ops person who's wanting to influence change, is there any kind of like tip that you'd give them on being able to influence a more improved ward environment? I think, Jyoti, you'd already started to sort of give one tip there, but have you got something else in the bag that you can give?
Personally, when I started my journey with this, we always had the first followers. So we had one specialty who would say, I'll try, exactly what Gordon said. When I said this consultant of the week model, people were horrified. You know, how can you do that? And then when cardiology did it for 3 months as a trial, all the 29 beds, I said, there was a give and take. I said, you do this for 3 months. In return, what you can do is give away your general ward. So you don't need to do, they used to do 2 wards, one cardiology ward and one general ward. I said, you give away your general ward, you just keep only cardiology, but I want 7 days a week, I want a ward round, and that commitment that you will, you know, manage your patients well. And we employed a locum to look after the general wards, because we can't generate consultants just like that. But that on the back of that, we could actually close 2 wards by actually having dedicated people doing board rounds and ward rounds on a daily basis, giving them the time to be accessible. And the first followers, after 3 months, they didn't want to go back to their old way of working. It was horrible in the week that they were actually doing the ward round, the consult of the week, because Monday is horrible. You inherit 29 new patients. But again, Ian Sturgis will tell you should start your consultant of the week on Wednesday rather than on Monday. So there are other ways of dealing with, but it's horrible on the first day, but it gets easier as you go along. Well, so start with your first follower is what I would say.
A great tip, and also sound evidence that it's worked. So a tip that works. We like that. Richard, Gordon, you're about to share something. Go for it, Gordon.
Yeah, I would just say, from my experience, get on and do something. Richard mentioned Atul Gawande. He more or less said, as physicians, stop moaning, do something and count. So I started trying to organize my ward rounds, and this is what I've currently ended up with on how to organize my ward round. So pretty much who is the patient at the top, what are the clinical problems, what's the background, the progress note, and today's plan and later notes. We type all this on the ward round now, print it off and file it into the paper notes. Very shortly we'll be going electronic. And then the active quality and safety checklist. Is the patient on an antibiotic? So are they at risk of C. diff, diarrhea? Should we stop the antibiotic, VTE prophylaxis? And then just an example of how this is constantly evolving. We found our pharmacists were saying that we were delaying discharges because we didn't know whether the patient was managing their own meds at home or needed a Dosset box or somebody else to administer the meds. So we just changed one of the previous boxes to needs help with meds at home. And that, again, just helps with the discharge process. So try something, keep on finding out what the problems are with it, keep on modifying it, and stick to it. Thank you.
That's great, Gordon. Thank you. Since you introduced this way of working into your own areas, did you notice any positive effects around quality, outcomes, or length of stay?
I think definitely around quality of care. The quality is much better. I think because we were following a process, everybody knew what was happening, So actually the ward round time didn't take any longer doing this. It seemed to free up some time for ordinary conversations with the patients, a bit more fun and enjoyment on the ward round, as well as patients being very grateful that they were being checked through thoroughly.
Excellent, thanks, Gordon. And I'll let you unshare your screen as well.
Yeah, I'll try and find how to do that. You might have it for the rest of your life now.
No problem. So, Richard, what about yourself? Have you got for a clinician or an ops person watching this video? They're already sold on the idea, but what personal tips would you say would be good for them in influencing change on ward environments?
Yeah. So you, I think, mentioned about people making a difference. How can you best make a difference? And I think that's a really important thing to get across. You want everybody in each role to be given the maximum opportunity to make a difference through what they can do. So I often talk about something I call the head chef model for ward cover. So when we're out of these COVID restrictions, and if you get to go to a nice restaurant, it's very unlikely that the head chef is doing every last bit of the process. They're not boiling all the eggs. They're not chopping all the vegetables, but what they are doing is they are overseeing the entire process, and they are taking responsibility for the quality of what they provide. And I think that's something that you can encourage consultants to do more of. So rather than a ward round consisting of wheeling a trolley from bay 1, bed 1 to bay 5, bed 5 and the side rooms, actually working out who needs to see each patient, who can address the needs of each patient that day. And that means that the consultant, what they might need to do that day is to have 3 really difficult conversations. And by doing that, that will make a difference to those 3 patients in a way that somebody else might not be able to, allowing the rest of the team to go off and see the other patients, to be given the freedom to make decisions up to the level that they feel capable, but knowing that they can come back and discuss those. So I think really rethinking the way that ward care is delivered can make a massive difference. It means that things that have to happen will happen. And also, I think it's a more rewarding experience for the teams that get to make more decisions. I find the more decisions you allow people to make, the more that they make.
Well, I just agree completely with that, and I think it's one of the big advantages of COVID-19 was that we could suddenly move away from the KEO model that every patient had to see a consultant every day, and we could decide during the huddle which patients needed to see the consultant, which ones could be dealt with by the junior doctors, and which patients maybe just needed a hello, how are you, and nothing else. And we've been operating that system probably now for 6 months. I saw it operating in Sweden as a standard way of operating the wards, that the night nurses actually decided which patients needed to see a doctor the next day. That gave a lot of respect to the professionalism of the night nurses, and again meant that 1/3 of the patients didn't need to be seen each day, so the other 2/3 could have more time. So I'm very pleased we've moved away from this. Every patient must see a consultant every day, and our junior doctors have flourished in that because, as you say, they've been given responsibility, allowed to make decisions, and in general, they make very good decisions.
I'm glad you said that, Gordon, because that's something which I found was I'm an obstetrician and gynecologist myself, and I've been so used to doing virtual ward rounds all the time, and I've never found that happen in the physician's territory. It's always like face to face. And I used to sit from my home and call my nurse on the ward, and the trusted assessment of the nurse is really important for me. If she says somebody can't go home, I will respect that much more than me going and seeing some flash 5-minute visit for me doesn't do much. I really trust what my nurse tells me about my patient. So that we've been following for the ages. And we have always taken, had safety netting. That was the other thing which was very different from surgical ward rounds and medical ward rounds. So we always brought back patients who needed some more blood tests, who needed the catheters taken out. We would send them home, bring them back for catheters. We would send them home, come back, bring them back for blood tests. We'd send them home or make a call 2 days later to make sure they were okay. These safety netting things we were very used to doing. And that's something which I didn't find. When I asked my physician colleagues, they said, but there's no time for us to do it. And I agree with that because they were never given the time to do it. So this is where these are enablers. We need to make sure that these are, if you have those enablers, people will take those risks. Like a trapeze artist, he will do many more tricks if there is a net underneath. But if there isn't a net, they'll be very, not take any risks. So yes, we need to build those safety netting things so that we feel more confident in discharging patients earlier.
You keep reminding me of things that I had forgotten about. So I think the communication with the nursing staff is vital. And Pete knows that I've been going on about nurse at the bedside. Well, since I came to Oban, when I left Worthing, I had nurse at the bedside, 1 patient in 5, and I counted the nurse going by and saying, "Good morning, Dr. Caldwell," as the patient being there. Here, we have nurse at the bedside 100% of the time. And again, because we've got the process, the nurse knows I'm going to ask about pressure area care, falls risks, VT assessments and things. So that really close working at the bedside with the nursing staff, and obviously if it's geriatric ward, the physiotherapist, occupational therapist, I think absolutely vital to getting the care correct, getting the ward round done smoothly and swiftly, and getting concrete plans as to how the patient can get discharged safely. So that working, what I've always believed that the nurse should be there, active participant in the ward round, has been proven by coming here. Quality of the care is fantastic. I don't think we don't get pressure area cares problems. The nurses are managing patients without catheters who are doubly incontinent. Superb nursing, and the trust in the nursing, respect for the professionalism, proper team working at the bedside makes such a difference.
That's a lovely note to end that question on. And as an observer to you 3 consultants talking, for me, there is definitely a flavour of that. There are tools that you can use, but those tools are fairly useless if they're not met with the appropriate leadership. And what's leaking out of you 3 in bags is your value set, is that as leaders you value teamwork, you value MDT, you value empowerment, appropriate delegation, that each member of your team is your team. And they each have value to bring, and they're all on their own learning journeys. I suspect actually those are probably significant reasons why you've seen good stuff happen in your areas, and that might be a good tip for people watching this video to reflect on. Listen, we've only got a couple of minutes left, and we've talked a lot about positive influences, but if we talk about sort of let's get real a second, is that there's lots of hindrances out there, isn't there, in the ward environment? And just to name 3 things, we can think about technology solutions and hindrances. We can think about workforce, we can think about capacity, but bearing in mind time, do you each want to maybe think about something where you have seen a hindrance in one of those camps, and maybe a soundbite solution as to what you've seen work? And so, for maybe technology, there is good and bad, isn't there? Workforce, there's, we're all have plenty of workforce issues, no matter what camp we sit in, but there may be alternative solutions you've thought of. And capacity, maybe right sizing beds or something like that, what capacity we've got there. But Pete, I'm going to come to you first. Sorry to pick on you, but any one of those that you've got any thoughts on?
Yeah, well, thanks, Chris. I've got thoughts on lots of them. I think frustration is, having watched lots of doctors on wards rounds. Obviously, I was a nurse many years ago, but the frustration of having to use multiple systems. I remember one consultant, one trust, he almost made me watch him do the TTOs, and I can't tell you what an unlean process it was. And it always bamboozles me that it's such an important part, the review, the board rounds, why we just don't take a proper quality improvement approach to it, learn from others, see what works. So I'll give you an example of, I think of East Lancashire, who came to talk at one of our ward round conferences. They have on all their ward rounds a ward-based pharmacist. And I know probably not everybody has enough money to do that, but the benefits of doing that, for example, are huge. But they're not just huge from a flow point of view, from a safety point of view, from a training point of view for junior doctors. But you know what, Chris, they're just ones that came to the top of my head. I could think of many more. I'll hand over to someone else.
No, thanks, Pete. Has anybody else got any thoughts on hindrances with a solution?
Well, we've mentioned Atul Gawande already, and when I was introducing the checklist, first of all, and I contacted him. He said, never introduce anything that slows down the overall pace of care. And I have no doubt that both our paper and computer bureaucracy is actively undermining patient care by being too time consuming, and at the same time you can't get the information out back into your head to understand what's going on. So when I showed you my quality and safety checklist earlier on in this broadcast, at the bottom it really summarizes everything that comes in the nursing assessment just into 20 checkboxes at the bottom, and I can understand it. And I think we really need to be attacking a big hindrance now is this belief that medicine and nursing are conducted by filling in lots of boxes. Now, of course, I've created new boxes, but those are summary boxes that actually tell you useful information. And actually, I believe that a whole lot of nursing care is done by heuristics, not by these strange pseudo-mathematical calculations like a Waterloo score. So one of the biggest hindrances we've got now is too much information at the bedside, so we can't find the information we need, and then we're lost managing the patients. So I'd love to really work hard on cutting down this bureaucracy, and again, retrusting professionalism of nursing staff, particularly, that they can summarize a patient in 2 or 3 sentences comprehensively and provide the patient care that's needed. And we don't need all this huge time-consuming waste filling in these forms. Thank you.
Thanks, Gordon. And talking about time, we've come to the end of our 30 minutes, but why don't we, if we go around the room, the virtual room, is that if you were to offer one final piece of advice or a sound bite to the viewers watching this who want to influence positive change in their ward flow environments, what would that be? And whilst I give the panel time to think for a couple of seconds, is that please, viewers, if you have a little look in the blurb beneath this video, we'll make sure that there's some really good links for you, things that have been referenced already by the panelists, where they've spoken about documents or perhaps hinted towards other videos. If you look down there, that's where we will list them. But in no particular order, Richard, what soundbite advice would you give to close?
So I think the biggest thing is to give people the ability to make decisions, to make changes to the maximum of their ability. So think about how you can change your ward processes. Think about how you can involve the whole team in decision making. If you've introduced huddles and you want to get the most out of them, record the outcome of the huddle, would be my other piece of advice. It's amazing what a difference it makes when the next day you can refer back to what you agreed to do the day before. So those would be 2 simple things.
Sound advice, Richard. Thank you, and thank you for your time today. Jyoti, what about yourself?
Completely agree with Richard. I think empowerment. I think the team that you build is what speaks for you, and you really have to make sure that you're accessible to that team as you know, completely accessible. I would say give your mobile number to your team and say you can access me anytime. That will give them the actual freedom to call you at any time and ask for any decision making if they are stuck. And you need that rapport. I don't want my nurse to go through a switchboard and try to contact me. She should be able to lift up the phone and contact me directly anytime if there's a problem. And that rapport should be there. Then only the decisions will be made in a timely way.
Thank you, Jyoti. Thank you very much indeed. Gordon.
Yeah, we keep on talking about Atul Gawande. I think he said really the difference between a good doctor and an excellent doctor is simply organization. So I'd say get your frontline work well organized, make it overt how you're organizing it, and the small matters just as much as the big in clinical practice. So missing a cannula that hasn't come out can undermine the replacement of an aortic valve. So the small is as important as the big. Get organized.
Oh,
thank you.
Right, Gordon. Thank you very much, and thank you for your time as well. Thank you, Jyoti. Tim, any lasting words of advice?
Yeah, just thinking about this, the culture of the NHS runs so deep in our hospitals, doesn't it? And to some degree, the ward rounds are kind of the ceremonies or the religious events of our hospitals, aren't they? So we're really messing with stuff that's really culturally deeply embedded. So I'd just go back to the Simon Sinek stuff and encourage people to start with why. Maybe to have that conversation with your clinical teams, with your nurses, your therapists, your doctors. Why do we do a board and ward round? What's the purpose? What are we trying to achieve? Because for a lot of people, it might just be, well, this is what we always do. Every day starts with this process. But that conversation about why, starting with why, I think is really important here.
Wonderful advice there. Always the why and less about the what. Really good, Tim. And of course, we've left the best till last. Pete, Gordon, what's your
yeah, I mean, agree with what all the other panelists have said. I think start with the patient and work backwards. I know it seems really obvious, and you know, I'm a bit of a lean guy, so does it genuinely add value or not? So, you know, there's a famous picture of Gordon with all the nursing documentation lying down next to it. So, you know, which goes on for about 7 or 8 foot. And you know what, if it doesn't add value, be brave enough to stop it. If it is genuinely valuable, someone will complain or say, bring it back. But I'd say that be brave and give this a bit of focus and, you know, move away from a performance management, sort of very typical management approach to it, to one of quality improvement. What are we trying to do? We're trying to reduce unnecessary waiting and also reduce burden on frontline staff. And above all, trust our frontline people. The answers are always there if you go and see, ask why, show respect.
Oh, thank you, Pete, and great last words. So we hope that this video was useful for you, watcher. All 5 of these fantastic people, clinicians, are accessible. You will see a contact detail in the blurb below the video. So if anything has sparked something, if you want some more advice or you want to link in with any of these fantastic peeps, then use that contact detail below. But for now, from myself, Chris, and from this wonderful panel, keep safe, and we look forward to hearing from you sometime. Thank you for watching.
Thank you.
Thank you.